Resuscitation. Let's have a conversation about resuscitation. There's many different types of ways, things. There's many different things you can do in resuscitation. There's many different parts of it. There's different age groups in first aid between infant, child, and adult. This mostly comes into play in resuscitation. Infant, for non-medical practitioners, is between 0 and 1. Child is 1 to 8 years old, and then adult would be 8 and above. Those are kind of your break points. It's not an exact limit either. For infant, 0 to 1 is pretty straightforward, but for child to adult, that break point, if it's 9 or, well, I mean, it wouldn't really be 6, but if it's 8 or 9, fine, fair enough. The idea behind the age differences here and why that's important is because when you're doing something like CPR, right? When you're doing CPR on a child, you're 4 times, double, etc., their weight potentially, depending on how large their body is. You don't need as much force. When you're doing CPR or doing resuscitation on an infant, it's completely different. Just because of the size difference, infants don't really have necks. They're just kind of a head on shoulders. There's a bunch of things you have to consider with ages. For this main section, we're going to be focusing on adults specifically. If you are in a workplace, many of the first aid courses you'll take, or much of the first aid training you'll take, will likely be adults only anyways. So this is the stuff that commonly you deal with. We may add in the healthcare stuff. We'll probably end up adding in the healthcare stuff and the child-specific stuff later. For age ranges, for healthcare providers, when they hit that 8 child adult break point, they don't actually look at the age, they look at whether or not they've gone through puberty. So there's a puberty assessment. You would not be assessing for puberty as a non-medical professional generally. That gets legally difficult for many people, and it's just people aren't comfortable doing that. So there's differences there. There's a bunch of other differences in resuscitation, and for a lot of people, this subject can be kind of hard to deal with. I like to, especially historically, and a lot of instructors that I work with like to insert a lot of humor into first aid courses to make things lighter, maybe using different styles in different sections. With resuscitation, if you have a large class, there is a really good chance that more than one person in your class has had someone in their immediate family or, closer to extended family die of a heart attack or a stroke. It's one thing, dark humor is one thing, but with, people you're trying to keep motivated, you bring up, their family member that's recently deceased, and things don't go well. So it's tricky to work in a lot of comedy in this section. Most 911 calls or emergency number in whatever country you have calls for anything that aren't like butt dials or false alarms kind of a deal. 90+%. It's a much higher percentage. I'm lowballing it, of paramedic calls are for something adjacent to a heart attack. They're just doing CPR all the time. They almost never do wound care. It's just CPR, 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 cardiac arrest, respiratory distress leading to cardiac arrest. It's just, they're doing this resuscitation stuff constantly. By and large, if you have virtually any first aid emergency, it's going to lead to this section. When things get worse, you have insufficient blood, and then you pass out, and then you stop breathing, and we're doing CPR anyways. Pretty much everything is going to end up here once things get really, really bad. Okay, when I'm going through this, I'm going to focus on some very specific techniques and some very specific ways to do things. I'll give you a bit of a story now as to why I'm doing that. And some videos may keep this in, some may cut it out, because this section, look, in some first aid courses are 8 hours and 4.5 hours of our resuscitation. Like if you look at healthcare providing courses for like basic life support or other things like that, 4 to 5 hours of your 8-hour day is just resuscitation. In a 2-day course, same type of deal, huge section. Even for adults, just doing basic workplace first aid, you're looking at 1, usually up to 2 hours, just CPR. Burns is like 10 minutes. Like a lot of this stuff is show a video, okay, whatever. But with resuscitation, this is a big, this thing is, from a teaching perspective, is like a monster within the context of the course, okay? I'm gonna be very particular with a lot of very specific things. It's likely that you, the general viewer, especially if you have a larger family, will have an opportunity to use this skill one time in your life at least, and you'll probably want to do it as right as possible, given what you remember. So I'm going to be very specific with some things. Why am I doing all this? What's with this rant? I'm going to omit the names of the organizations involved with what I'm about to tell you because of the story and the potential liability here, but you'll understand the importance of why, and the message is important. The idea I'm going to get to is practice does not make perfect. Perfect practice makes perfect. You can practice the wrong thing over and over and over again, and when you panic, put your mind into doing that wrong thing. This kind of spoils the ending, but you'll see why. Years ago, lifeguards were being trained by an organization in a jurisdiction somewhere in North America. They were being trained on how to do CPR. The training they would do is they would stand over or kneel over another person. So it was a person to person. They weren't using mannequins. They were using another lifeguard. They would put their hands on their chest and they would simulate compressions, not pressing down the depth required, but they would just simulate the idea because they don't want to do full CPR basically on somebody who is conscious, because you can break ribs if you use a lot of force, and fair enough. And you know, if when you're learning, maybe you do something in error, you go farther than intended. I get it. They don't want to have the liability of person doing CPR on a person. Okay, the same thing here is true of when you see CPR done in most TV shows when it's simulated on a live actor. They're just going to put their hands over top and do CPR. So the lifeguards were learning that, and they were doing their drills day and day and day and day doing that. And then when they went to the breathing portion of doing mouth-to-mouth resuscitation, they would put their mouth next to the head, they would turn the head towards them, and they would go breathe, breathe. So they would put their hands over, breathe, breathe. Hands over, breathe, breathe, right? And they do the standard 30 compressions, 2 ventilations thing, back and forth, back and forth, back and forth. But they worked into their muscle memory, hands over, breathe, breathe. When it came time for them to do first aid on actual people that were drowning, some of them had worked in the muscle memory from the training to such a degree that the person's drowning, they get them out of the water and they put their hands over and then they turn the head and went breathe, breathe. So, you know, they do this, they're not pressing down for anything, breathe, breathe, this, breathe, breathe. And people went, what are you doing? Right? Because it's ridiculous. And I mean, and if I told that a different way, it would be a joke and it would be funny and be like, haha, you know, this is ridiculous. And you could work that into a comedy act and it could be hilarious. I did it in a fair serious and somber way to, you know, help emphasize the point here, but hopefully you can get the idea as to why I'm going to be pretty particular with certain things. When first aid videos show you how to do CPR, and they do it in a way that is sloppy, and especially, well, with video it's one thing because the instructor isn't teaching you the muscle memory. If a class has you learn CPR and they're not particular on the method, you might work the wrong method into your muscle memory, and you might, you know, oh my God, they're dying. You just reset into whatever you practice. You practice and you're doing something that's pointless. So some of this stuff is really particular. It's not difficult. And I'm going to go over the specifics to get your form kind of as close to perfect, which there's no real, it's a lot, this is all like strength training where the exact form you use might be slightly different based on your body type and shape and etc. Not everyone's spine is like the same curvature and length and etc. So I'm going to kind of approximate you, but there's some, once again, some very specific things that I'm going to focus on, especially when we get to that section. Also, the reality is that we're talking about some very complex conditions, cardiac arrest, angina, heart attacks, things that otherwise lead to cardiac arrest can get kind of wordy and sciencey, fair enough. So I'm going to try to simplify that as much as possible to the core sort of idea behind what you would, the sort of symptoms and signs and stuff you'd look for. And then we're going to point you to some other resources that you can look at for more up-to-date or more in-depth specifics, because the reality is, in my opinion, for learning about heart attacks and strokes and the type of thing where you're very likely going to be interacting with this on a family member or yourself at some point in your life, you might as well talk to a bunch of cardiologists, like people that literally study this specific thing One example of that, a resource in my area would be the Heart and Stroke Foundation, any number of the colleges of physicians. There's a whole bunch of things, and we'll see if we can add in and edit a bunch of links right here of things you can look at, or a bunch of references of places, and we'll put links in the description so that you can go look at those. I mean, they're like, look, these are people that study the heart and how it works forever. They can give you fun videos and diagrams and blah, blah, blah. So I'm going to give you the short version, and I'm going to focus really on the particular form, because that's something that I don't think we get enough of, the exactly how to do it. On that note, let's talk about the different sorts of conditions that can lead to a cardiac arrest. And there's two in particular that you deal with a lot in resuscitation. And they are a blockage, a clot basically in a blood vessel towards the heart, often called angina if it's partial, or heart attack if it's a complete blockage. And then we have the blockage in a blood vessel towards the brain, which leads to a TVA or a CVA, otherwise the CVA known as a stroke. The difference between a TVA and a CVA, and we can give you the long names for them here and here, which don't worry about that, is basically how long the thing went for, and more importantly, whether or not the clot caused brain damage. It doesn't really matter for you. You can't treat angina versus heart attack really any differently in a first aid environment. You're still responding to the responsiveness regardless. It might change how quickly you would identify something or activate emergency help. Hey, let's get to a hospital. But the physical stuff you're doing doesn't change. With stroke, the two different TVA, CVA things, it doesn't change the signs and symptoms really. Like, it's the same thing, which we'll get to in a second. So a lot of these terms, the difference is it doesn't matter much in practice for first aid, but it does matter for you to be better equipped to identify the condition sort of outside of first aid, so that you know, hey, maybe I need to see a doctor earlier. Because first aid is specifically that like first 10 minutes once the emergency is already happening, it's so specific that this stuff is kind of outside of it, but it relates pretty heavily. So, okay, angina and heart attack. This is the clot that is generally on the way to your heart. What will happen is, due to any number of reasons, decisions of eating certain things in life. I can harp on you now about why, bacon cheeseburgers are bad for you and blah, 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 but whatever. The point is, and you shouldn't smoke and blah, blah, blah. Whatever reason, there's a clot in a blood vessel. It's usually arterial. That's the bad thing here from what I recall from the cardiologists that taught me a lot of this, but whatever, blood vessel. You have a clot in a blood vessel. There is a lack of blood getting to the heart when you have this problem. The heart is a muscle. Your muscles, right? Your muscles need oxygen and nutrients and stuff that your blood delivers to them to stay healthy and grow and do all the stuff that they need. The heart is a muscle, so while the heart is pumping blood, it doesn't necessarily feed itself the blood through the walls. It also has to kind of redirect the blood to itself. If blood doesn't get to the heart on that other area, so if there's a block in a vessel there, some of the heart can start dying. This heart dying, over time, is what generally causes your heart attack symptoms. Why does this matter? Heart attacks can show up symptomatically up to 4 days before you go unresponsive. So you can be having a heart attack and symptoms could start showing days before you pass out. That's really weird. Like, conceptually in first aid, most things are really fast, right? Things are really quick. Heart attacks have a lot of this really early warning sign stuff. Now, there are a lot of heart attack symptoms. The reason for that is because the heart is going to, this is not exactly true, but just kind of think about it this way. It worked for me to think about it this way. The heart is basically sending out emergency signals of there is a problem going on here once it starts dying. So it's going to not be pumping blood as effectively, and that is going to have certain weird things happen. And because it's going to die or start dying more and more and more over time, these symptoms will generally stay the same or get worse. If you were to walk through a room and then, clumsily stumble into something and hit your shoulder and you hurt your shoulder. Your shoulder would have pain that would likely radiate. It would pulse. It would go away. It would come back. You would have some swelling maybe, but it's not solid pain. Generally speaking, with heart attack symptoms, this is not always true, but generally speaking, you have consistent, similar symptoms for a very, very lengthy period of time. Look, if you have jaw pain, your jaw is just generally uncomfortable or hurts for like 9 hours, and it's just been the same or got worse, it is time to consider a hospital. Okay, like it has been time. If you have no appetite, so you don't want to eat at all, and you haven't eaten anything for a day and a half, remember the whole shock section about you go into medical shock and then the blood goes away from your stomach because you're trying to save heart brain? Well, if your heart isn't getting what it needs and it goes into emergency, it might start activating medical shock and doing stuff like that and sending blood away. You don't have an appetite. If you're not hungry for a day and a half, and it's not because you were, you're a professional eater that just put away 40,000 calories, like, a few moments later because you're doing an eating challenge, because, fair enough. But, if you're not hungry when otherwise you should be for an extended period of time, that's not normal. If it's not a heart attack, it might be something else that's still not normal where you might want to go to a hospital, right? You have pretty much, right, any problem between the jawline and the end of your digestive system. So pretty much anything from the jawline through the entire core to the exit, anywhere in there for an extended period of time. Look, if I had that, I'm going to a hospital. Now, I, once again, live in a country where I can just go to the hospital. So I can appreciate how if you're in an area where I don't know might be expensive. Fair enough. Were I in that situation, the best thing that I would do would be to try to find some way to get that sort of question answered from some resource that would be cost effective. Because look, if you don't go to the hospital and you think, let's say you think you have a heart attack, you think you're having a heart attack, and you don't know if you are or not, but you think you are. And let's say you're wrong, and you're wrong, you don't actually have a heart attack, and you don't go to the hospital, okay, you save some money. Or you don't go to whatever way you have to try to find that out, you save some money, fair enough. Let's say that you are, you think you're having a heart attack, and you don't go to the hospital, because it costs money, and it turns out you were wrong, and you were actually having a heart attack. Or just you were right, you were actually having a heart attack. Well, now you're dead. So that's not good. That's risk management. It's tricky, right? This is the tricky decision people often have to have. When in doubt, if you're in a country where you can, get this checked out, just once again, get emergency services, go to a hospital. In Canada, in a lot of jurisdictions here, if you have a panic attack, which is often confused with a heart attack, we will actually, the paramedics don't get really irritated about that, generally speaking, as the ones that I talk with and the ones I've discussed with. The standard protocol that I've kept hearing for years and years and years, I'm speaking as them acting now. I am not a paramedic. They'll say, we see panic attacks all the time. And frankly, we're happy to show up and find out it's just a panic attack, because at least they called and at least they didn't not call, and then we respond to someone who was deceased. Right, so that's generally what they say with it. There are ways to tell the difference between a panic attack and a heart attack. That's not going to get into that right now, but even then, that you can still be wrong. It's complicated. Fair enough. Look, go to hospital if needed. So once again, problem between there and there and there extends for a period of time. You should heavily be considering whether or not you have a heart attack. You may have heard before, left arm heart attack, right arm stroke. That doesn't bear out. It could be either arm. Stroke signs and symptoms are very specific. You got a problem between there and there, assume hospital. Once again, broad discomfort, general indigestion, lack of appetite, nausea. Look, if you're nauseous for 7 hours and it's just solid, consistent, if that's caused by food poisoning, you're probably considering a hospital anyways. Why are you nauseous for 7 hours? right? Morning sickness doesn't last for 7 hours. So morning sickness is a nausea that women will go through when pregnant. It just doesn't, you're not nauseous for that long unless something's really, really wrong. Now, there are sometimes a symptom that appears to be a heart attack symptom that is something else. Very often it's a different organ that's failing. Well, an organ is failing, you're probably going to a hospital anyways. So when in doubt, you should probably be in the hospital regardless. Okay, so that's basically angina and heart attack. There is some specific first aid that is relevant to angina and heart attack as well, which is a nitroglycerin patch and aspirin or acetylsalic acid. So depending on what jurisdiction you're in, you may be dealing with nitroglycerin. Nitroglycerin comes in tablets, patches, sprays, all sorts of stuff. You're not going to be administering this medication, but they may have it. If you bare somebody's chest in order to do CPR on them, because you're going to have to take people's clothes off, not their pants, but like the chest area is going to have to get bared because you're going to be attaching a defibrillator to clear right on them and all that. You may see a patch, like just a patch just there. That has a medication on it that is very strong that lowers blood pressure. If you have to take that patch off, make sure your hand is gloved because it's designed to rapidly absorb through skin. And if you take high strength blood pressure medication while your heart is racing because you're panicking, you could just pass out. Which means you're not doing first aid. So gloved hand to make sure you're not absorbing that medication. You can take the patch off, the nitroglycerin patch off if need be. The most recent recommendation I've seen with nitroglycerin patches is you don't want to shock over top of them because of potential fire hazard. That was the most recent one that I've seen. They may have changed the patches. They may have changed defibs over time. You know, years after this video comes out, this may change, but the current recommendation is gloved hand, remove patch, and then continue on with whatever you're doing. So that's the thing. There's also acetylsalic acid, otherwise known as aspirin. Aspirin's the brand name for it, so ASA. Aspirin has been recommended for dealing with heart attacks for a very, very, very long time. If you identify someone's likely having a heart attack, you can give them aspirin. It'd be 1 regular dose or 2 low dose, and they chew it. They don't swallow it. You have them chew the aspirin and absorb it in a powdered form once chewed through their gums. You will absorb aspirin into the bloodstream much faster through your gums than you will through the stomach. And frankly, if they go unresponsive the second they swallow the aspirin, now they're choking. And now your first aid gets, or your CPR especially, gets really complicated. Well, okay, not really complicated, but it gets more complicated than it might have otherwise had to be. Okay. So we chew the aspirin as a thing. You can actually give people, oh, this changes on jurisdiction too. Yeah, it does. That's not necessarily the same everywhere. Here, we can just give people aspirin and they can take it and they can chew it. You're not putting it in their mouth, like moving their mouth for them. I'm not certain about every jurisdiction in the world if you can actually do that. So double check if you're allowed to use aspirin everywhere, or ASA, acetylsalic acid. Acetylsalic acid. So just double check with that. Now, do not confuse aspirin with Tylenol. Aspirin acetylsalic acid is used for this specifically. Tylenol, acetaminophen, can often be used to control the temperature in a child who has a fever. Completely different. Acetylsalic acid, if you give to a child, can cause Reye syndrome and kill them. Acetaminophen doesn't do anything for heart attacks. So we've got one that's for heart attacks, generally an adult, but well, no, heart attacks in an adult because you don't want to give them Reye syndrome. So heart attacks in an adult, and you got the other, which is temperature control in children. Completely separate, okay? So keep that in mind. Also, another aside, because this has come up frequently for years, there's a lot in this session. Do not call, if you can, do not call low-dose aspirin baby aspirin. The nickname for low-dose aspirin, baby aspirin, was used for years, and what happened was, and I mean, this is one of those things where someone's going to have to find a way to verify it for me, because I've kept hearing story after story after story after story, but this is technically all anecdotal. I mean, I've heard stories from pharmacists and medical professionals, but I didn't ask for the research in this because the trust me bro just made sense given the source that was telling me the story. And I've heard it from so many places that I just assumed it was true. But anyways, when the term baby aspirin was used, People that didn't have like an explanation telling them that that it's just a nickname and not to give it to babies, they thought aspirin was good for babies, and they gave aspirin to babies, and then the babies got Rye syndrome. So it's one of those, the word confused people that didn't have the training, and then they thought it was a good idea when it wasn't. So when possible, just say aspirin or low dose aspirin. Try to work baby aspirin out of your vocabulary if it's in there, because there are some potential for word of mouth downstream effects, people just using it wrong. So yeah, that's a thing. Okay, one more thing on angina. Technically, angina is a heart attack, once again, where it's not a full clot. So the heart attack, the vessel is completely closed. The heart muscle starts dying. With angina, it's partial. The heart muscle won't necessarily start dying. You'll have heart attack-like symptoms, go away and come back, and go away and come back. Angina is basically a warning call that a heart attack is becoming much, much more likely or risky. So if you get very, very winded and you get a whole bunch of sort of heart attack symptoms after you exercise, you may have angina. It may be a thing, and you may still be on heart attack medication for it. These people should be, or I would say should be, on the lookout for a more likely heart attack in the future, because the vessel's starting to get constricted, it's starting to get closed. It's not completely blocked yet, but it's much closer than somebody that doesn't have angina, right? So there's that. That's heart attacks and angina in general. Stroke, and the brain one, clot on the way to the brain. Your concern is brain death. Now, when the brain doesn't get blood and oxygen, it starts dying. Brain cells start dying in 4 to 6 minutes. You see immediate signs and symptoms for this stuff. It is right away. So some of the stuff that you will initially see right away, you're going to see facial droop. So you're going to see the face start drooping down. And it's kind of hard to mimic this, but I'm going to see and it's paralyzed, right? So half the face, half the body can potentially be paralyzed. If you're in Canada, you may remember our previous Prime Minister from many years ago, Jean Chrétien. He has Bell's palsy, which is the symptom or sign is the same essentially as a stroke. If half his face is paralyzed, it's drooped down. So if you see that, you'd be like, oh, yep, that makes sense. So facial droop is one. You've got arm drift. So if you raise both your arms and one doesn't, right, or one's difficult, you have half body paralysis. That's the idea. You've got slurred or difficult speech. So the brain helps govern your ability to form words and put correct emphasis on the appropriate syllable, right? You do all that. So they'll have difficulty speaking. How are you? How are you? What do you want to eat for dinner? Gargamel, right? They say, what is this? So they may say things that are odd. They may actually hear what you're saying or think they do, and they might be thinking they're saying the correct thing to you, but then they're saying something completely nonsensical. So they may actually think they're having a normal conversation, but it sounds like something completely out there. Okay, facial droop, arm drift, paralyzed, half body, slurred speech. If you have those sorts of symptoms together, you want to make sure you get them to medical help immediately on a very short time span. This makes the magical acronym FAST. Facial droop, arm drift, slurred speech, time. This is something that has been put out by Heart and Stroke Foundation and other organizations for years. You may have seen an ad for this on TV. This has just worked, and yep, it's just worked. It's a great acronym. It works. That's when you're having a stroke. Go to a hospital. Ta-da. Once again, this is not something that's going to be happening, days with days warning. This is going to be more immediate. You're going to notice it if you're looking for it, and off to the hospital we go. Okay, that's heart attack, and then that is stroke. There is something that is often referenced in first aid courses, depending on the jurisdiction, called the chain of survival. It's kind of a public service announcement about the steps that are involved in doing first aid associated with a heart attack. The number of links in the chain and how it works and that changes depending on, even within Canada, what jurisdiction's teaching it. There's a lot involved in this. I'm going to give you the simple version. Okay, look, if you're dealing with a heart attack, the earlier you figure it out, the better. Because if you get to a hospital in the first day of the heart attack, before they go unresponsive, less heart muscle has died. the medical intervention is easier, and you're not doing CPR because they're conscious, talking in the hospital, having a heart attack. When you catch it early, all of this stuff gets easier. So number one, early identification is going to make your life way simpler. Second thing, if we get to the point where the person is unresponsive and we're doing first aid and CPR in this case, because they'll be not breathing at some point, and if we get to that point, heart attacks ideally have cardiac arrest more specifically. The heart is, how to put this, the heart is in arrest. Oh no, that's pretty much what cardiac arrest means. When that happens, you want two real components of this. The first is CPR, so chest compressions, chest compressions, chest compressions should be started as early as possible when it's been identified that they're not breathing. That's number one. And number two, you ideally want a defibrillator. Now, in the public environment, you will likely have what's known as an AED, an automated external defibrillator. So you won't have the thing that you see in movies where they put the pads together with the ointment and go clear and then shut. No, you're going to have something where you attach it, and then the machine will talk to you and it will tell you, hey, do this, do this, do this. Hey, get off of them. I'm analyzing the thing. Hey, it's time to shock. You really don't want to be on right now. Click the button. Don't touch them or we all get zapped together, right? It's going to talk you through it. You want both, ideally. If you have to choose between one or the other for whatever reason, do the CPR. Look, if they're having a heart attack and they're not breathing, and paramedics are 10 minutes out and you do nothing, they're dead. They're not like, and there is a very, 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 very small chance they're not dead. Statistically speaking, like probability speaking, they're dead. If you do CPR on its own and it is immediate, depending on the stat you're looking at, you're getting somewhere between a 1 to 5% chance of them being revived, because heart attacks are pretty serious business. What will likely happen with a very serious heart attack is you will be doing CPR the entire time until the paramedics get there. The paramedics will take over and they will do CPR in the ambulance into the hospital, continued the entire time. They're going to get to the hospital. The nurse is going to take over and the nurse is going to do CPR the entire time, and they're just going to keep hitting that heart until they can get the person to a surgical room where they can then start fixing the problem. Okay, and if they resuscitate them because with a heart attack, they still have the clot, the heart is still dying, the person will just potentially go into cardiac arrest again. So it's just a continued thing, and you're kind of just hitting the pause button on them continuing to die, but they're still in a very bad situation. Okay, that's just the reality with heart attacks. If you don't do that, blood isn't pumping, brain cells are dying, we don't have much of a chance at all. So you're looking for a very small amount. One of the issues that happens with this heart attack stuff is the heart, when it goes into arrest, starts beating in ways that just don't work. There's a bunch of irregular sort of heart rhythms you can go into. There's too fast, which is tachycardia. There's too slow, which is something you never deal with in first aid. It starts fluttering in weird ways, which is fibrillation. The heart basically ceases beating at all, which is that flat line. That's asystole. There's a bunch of different words for these things. A few of these rhythms, specifically the fast one and the shaky one, the flutter one, if you defibrillate, the heart just kind of resets and it starts beating normally again. Ideally, you can reset those rhythms with a shock. This can, because this is what will happen often with hearts and heart attacks, this can kind of buy you a lot more time. The defibrillator gives you that, but if you're not pushing the heart, the chance of the defibrillator working on its own is so low, you should have just been doing the CPR. Here's a bunch more numbers. Chance of survival with a heart attack without CPR, basically zero. Chance of survival with a heart attack with only a defibrillator with no CPR, basically zero. Chance of survival with a heart attack with only CPR, 1 to 5% somewhere depending on the stat. Chance of survival with CPR plus defibrillator, as long as both start on person within 2 minutes of going unresponsive and not breathing, 75 to 80%. 0, 0, 1 to 5. Ooh, like, whoa, that's a big jump. Now, this assumes everything is on early. This assumes the person doing it knows correct form, is fast, like that you know what you're doing and it's done correct. But even like that stat that I just pulled out there was something that was told to me from responders looking at Canadians in a particular jurisdiction responding to a heart attack and stroke that were trained as first aiders. That wasn't even paramedics getting those kinds of numbers. Defibs are good. Defibs are really good. They don't replace things, but man, they're good. So just something to think of. They can be expensive though. The thing is, very often in public places, if you see kind of like a sign with a heart and a lightning bolt on it, with like an alarm cabinet, that's probably the defibrillator. A lot of sporting arenas will have them. Large stadiums will often have them. Movie theaters will have them. Malls, almost all of them by now in most larger countries will have them. Defibrillators are actually everywhere. You don't have to buy one yourself. You can probably find one. So just keep in mind, they might exist around you and you might not even know it. Okay. We talked about all that. We talked about, once again, early identification, the types of things that you want to have when you're doing the CPR. Let's say that doing all that, CPR is great. At some point, you do need emergency help to get there because you're not fixing the clot. The clot is still there. You need medical help. If you wait 10 minutes to call an ambulance when this happens, you're just doing CPR for longer now. Call early. Go to the hospital earlier. You require medical help for this problem. A heart attack does not resolve on its own. You need medical intervention for this. Okay? So just do that earlier. After this whole thing has gone on, what is going to happen in your treatment is you're going to be having conversations with doctors, or the casualty will be having conversations with doctors, assuming they survive, about changing health and habits around what they did that would have caused the clot. This is going to be a fairly dark joke here, but it will illustrate the point. This has happened, but it's not frequent that this happens. And once again, this illustrates the point. Person gets, resolves their heart attack. They're in their hospital bed. They get discharged from the hospital. 2 weeks later, they go to a meeting to find out about all the fun things they can't do. When they get to the point where they tell them they can't have a bacon cheeseburger surrounded by donuts, the sheer shock from this and the startling causes them to have another heart attack. Oh no. Should I or should I not go to the meeting? Okay, so yes, dark humor, not very great delivery, I get it. But you see the point. People don't want to do the sorts of things generally. They don't want to give up the stuff that they end up having to give up to not cause another heart attack, the sort of bad habits they were. Look, I get it. I get it. You're going to have the conversation. It might sound preachy. They're going to go over all the sort of things you're just not allowed to do anymore because you want to be alive or not. There's no easy way to put it, really. Sometimes, depending on your condition, you'll be given the choice of, you eat this, it'll kill you. You eat this, you'll hate it, but you won't die. You're going to quit this or not, right? That sort of thing. Life decisions are life decisions. The cardiovascular system has its limits. Have the conversation and good luck. I'm not going to get into the specifics of what the optimal diet is or anything, because that's not the point here. The point is, when your doctor tells you to do something or you will die, you should probably take it seriously. That's the point. Okay. I'm sorry that this is so dark. I'm trying. It's very hard to make this light for me. We've just seen so many resuscitation things, and it's such a serious topic. Okay.